Thanks very much. Thanks, Adrian. I feel a bit ashamed to talk about something so prosaic as services after such a beautiful poem. But I'm proud that the work I'm going to present is not just mine, it is also the fruit of yesterday's work. We had a wonderful workshop with a group of people with many hats, co-led by my colleague Peter Groot from the User Research Center in Maastricht. And it was actually very nice. So a lot of ideas came out, and we also spent some time on how you translate these beautiful ideas to practice. So I'm going to present that, and I'm going to start with a paper we wrote about 20 years ago in the British Medical Journal. And we wrote about how all different European countries have different mental health services, so that apparently nobody agrees on what a mental health service should look like. So anybody from abroad, anybody from overseas, as they say it, non-UK? Ah, yes, quite a lot. So all countries. So we haven't found a solution, and that is very interesting in itself. So it clearly shows that there's more work to be done. Of course, context is very important. Maybe different countries, different locations need different services, but there's clearly a need for change if you see it from the European perspective. There's also, I think, a need for change when you consider the instances when actually people try to assess the quality of the service as reported by users. And this is a bit of a controversial report. It's a report by the Schizophrenia Commission a couple of years ago in the UK. But I think it was a very courageous report, because the conclusion was that mental health services in the UK were dysfunctional and not up to the challenge of the 21st century. And this was quite a shock also to, for example, people in the Netherlands and in Germany, because we always look to the UK as one of the countries guiding mental health service developments. And if it's a dysfunctional system in the UK, then what does that mean for the system we have in other European countries? So clearly there's something going on there that requires reflection. But maybe the most important idea for change comes from wonderful people and allied disciplines and researchers and scientists who are outside the mental health system and sort of look at the people working there, the people using it, and make important contributions and reflections. And I'm going to discuss a number of these observations from different disciplines and allies and people, and see in what sort of direction they make us think when it comes to change. So I have a background of epidemiology, and the epidemiologists actually have a sense of wonder when they look at mental health services, because they say, well, you have developed this system, the diagnostic system, and then you go out into the population to assess the prevalence of mental disorders, how many people need mental health services, and then you come to this staggeringly high prevalence figure of 25% in a year. So a quarter of the population, according to your diagnostic system, needs some sort of mental health service input in a given year. And they say, well, this is very interesting, because it clearly points, if this is true, then this clearly points to the need of a so-called public health model. Because mental health services may be able to cater for 3 or 4 or even 5% of the population, but they can never cater the needs of 25% of the population. So where is your public health approach? And this is very interesting, because in none of the European countries, indeed nowhere in the world, is there any public mental health system that, for example, targets root causes like social inequality, discrimination and stigma, or looks at prevention, or has online communities where you can educate yourself about your mental health, etc., mental health promotion. So there's none. And there have been many people calling for public mental health. There's a paper in The Lancet and one from Christian Wahlbeck from Finland, pointing out that there is a definite need, but to date there's none. So with everything I'm going to say, let's agree for the moment that there is a need for a public mental health system. And then we have, space for a mental health system on the ground. And what does that look like? Well, there's a bit of a problem there, because the philosophers are also looking at the phenomenon of mental health and the mental health service and a system of mental health. And one of these philosophers is a man called Michel Serret. And he has a very interesting observation, because he says, as soon as you create a system for something like mental health, it becomes meaningless, because that's the quality of a system. If you say mental health is a system outside of other areas of life, it becomes meaningless, and all it starts to do is maintain itself and become disregards the people it should serve. So like the car here is meaningless because it can't drive. This is the same with any system you're going to try to build for something like mental health problems and mental distress. And there's been many courageous people in the past who have said, well, if you want to have a mental health service, it should be integrated. It should be integrated with social things, social services, with GP practices, with things that count in people's lives. And there was this wonderful plan that Ian Falloon had 30 years ago for an integrated service. And he nearly got European money to conduct some research and do pilots. And then he didn't get the money, and he left disappointed for Italy, where he retired. So there's still a need for integrated services there. And users are also wondering, and this is very interesting because we talked about this yesterday as well, users who make use of the various mental health systems in European countries say, well, why do you always know everything? Why do you always say you know everything? You say, well, you've got diagnoses and guidelines, and you can measure my improvement. But in fact, when I look critically at you, the level of your knowledge, your scientific knowledge, is not nearly as strong as you imply it is in interactions with me. So users say, well, not knowing is also a form of knowledge, and maybe that's your most important form of knowledge, and maybe you should try to disseminate that more. So, for example, we talked yesterday about the example of somebody getting a diagnosis of schizophrenia, as if it is a thing, and then being prescribed an antipsychotic. And that antipsychotic then is the model will improve the schizophrenia symptoms. And you can measure that. But if you look at it from a different perspective and really, the level of knowledge that is surrounding this model, you could equally well say that there are individuals who will present in a mental crisis. And, we as a profession, we psychiatrists, we propose then people can experiment with molecules if they want. Molecules we know have an impact on the brain, but we also know there's a huge variability in the way these molecules impact the brain. So some people will get worse, some people will have no impact, and some people will improve. But we can't predict who will improve, because the knowledge and the precision with which we can predict based on the group-based statistics are not very precise. So this is a better model, perhaps, talking in terms of not knowing rather than knowing. It's an interesting area. So there's then the anthropologist. And anthropologists are also very interesting because they study the mental health system and the people who work in it. And this is work from Woo Kyung-an in the United States. She works in Yale. And she studied mental health professionals in the sense of what they had in their heads in terms of concepts about mental distress and mental crisis. And she discovered that there was this underlying dichotomy in how we view mental distress. So on the one hand, we have a notion that some things are extremely serious and are of biological origin and require physical treatment. But we also have the notion in mental health system that some other things are milder in terms of their manifestation, are of psychosocial origin and require psychological treatment. And again, when you really study these things, there's no evidence. There's no evidence to say that adjustment disorder is more or less of a brain disorder than the diagnosis schizophrenia. So these are just notions, informal notions underlying the concepts and the actions of mental health professionals. So this is very interesting observation. Of course, the extremely serious version of this dichotomy is, for example, the diagnosis of schizophrenia, which is typically presented in journals like Science, like a genetic brain disorder, which is clearly what the anthropological evidence shows as well, that we like to use these language in scientific journals. But there's also, a wonder of the psychiatrist. So Alan Francis points out, very interestingly, because you probably know him, he designed DSM-4, he was the chair of DSM-4, and then when DSM-5 came out, he became a vocal critic of the whole system, because he has a very simple observation, namely that a warning that if you present, for example, with fluctuating emotions, or if you present with hearing voices, then you can say, well, you've got bipolar disorder or you have schizophrenia. But the implicit mistake you can make is saying that these are caused by these diagnostic categories. So the model you convey to the person with the fluctuation emotions or the voices is that there's some sort of entity that causes these phenomena. And once you're on that track, you become dependent on the knowledge of the person who will give you this diagnosis. And it is disempowering, of course. So there's I think these are very interesting observations when you talk about changing services. You have to talk also about what is the language and what are the concepts that are conveyed by this language and what is the impact of this language and the concepts on the people making use of these services. So perhaps the distinction that is underlying these observations is that you can have, on the one hand, a system of sick care, and this is what health scientists, when they look at mental health services, observe. They say, well, there's certainly good elements in it, but it's purely a system of sick care, diagnoses, guidelines and measurements to see if people have improved. But where's the healthcare component in this system? How can you marry a health perspective to mental health services rather than it just being a sick care system? And this is interesting because the concept of health is changing. It's not just in mental health that we talk about health and changing services. There's a huge change going on in health services in general in what they think health is or should be. So health used to be, according to the definition of the World Health Organization, the absence of sickness. But now there's a new definition that was published a couple of years ago in the British Medical Journal that is gaining ground very rapidly and is very popular. And this is that health is the ability to adapt and to implement your own control and self-management in the light of all these challenges that you can have, physical, mental, and social. Of course, this is a concept of health that is much closer to the recovery concept that has been playing a role in mental health services for a long time and is trying to gain ground in mental health services for a long time. And the interesting thing, I think, is that in health services and in hospitals, this concept is gaining ground very rapidly. So, for example, the way cardiovascular problems are diagnosed in the hospital is changing. So it used to be that if you had pain on your chest, that they would try to visualize your coronary arteries and see if there was structural pathological changes in the tissue, and then give you a diagnosis of heart disease. But this diagnosis is changing. What they do now is they put you on a bike and let you cycle and harder and harder and harder until you start having pain. So what they're interested in terms of diagnosis is what you can do, how much capacity you have, and what sort of room there is for thinking about new goals in life, etc. So it's a different way of diagnosing that is not relying on the sickness part as much as it used to be. And you can apply this to mental health as well, because there's a lot of evidence. It depends on how you look at it. There's also wonderful research, for example, like this paper, showing that the genetics associated with the diagnosis of schizophrenia, when you care to investigate it, can be shown to predict creativity traits in the general population. So this is work from Iceland. Iceland is a very interesting country because they can do this type of research. And this was in a very reputable journal. And once you start doing that, you can also think of psychosis, of course, not just in terms of an illness, but also in terms of a journey or a spiritual crisis. That, the concept of the wounded healer, and that although you're wounded and although there's a lot of work and a lot of adjustment and a lot of challenges, there's something that requires this travel, and you can also learn from it. And there's no other pointers to changes in that sense, because literally the psychedelic drugs that used to be the street drugs, to have intense experiences, if you like, intense spiritual experiences, are now used or investigated as psychotropic drugs. And it's very interesting. So things like ayahuasca and psychedelics and psilocybin used to be the bad guys, but now becoming the good guys. And although they make people, as it in the trials, they say they make people slightly psychotic, they are now also used for example, their effect on emotions and their antidepressant effects, and they're used in PTSS and traumatized people. So they're much more seen as drugs that are facilitating recovery, perhaps because of the spiritual effects they have on people. So things are changing there, and I think this is important because it shows that the system is a bit moving towards health concepts as well. And then there's sociologists. I like this sociologist. She's Dutch. She's called Christine Brinkgeven. But she wrote a book recently in the Netherlands, and basically it was about, tell your story. And the neglect we have in health services for storytelling, and how people, through development of narratives, can find ways to recovery and healing. And it's a very interesting notion. And what is more important is this book was an absolute bestseller and is very popular with people frequenting mental health services. And it's bringing about change. So something shows that apparently mental health services are ready perhaps to embrace these concepts. And of course, this is very well known, again, from the recovery movement, that recovery is in part also reinventing yourself through a narrative development around identity and meaning of your experiences, and having a different sense of purpose, looking for new goals in life and community. And of course, this starts with being overwhelmed by experiences and struggling for a long time, but perhaps at some stage, although it's not a linear process, but there's moments where you're living with and living beyond, etc. So this narrative model is also gaining ground and is, I think, ready to be embraced by mental health services. And of course, the tremendous challenge that presents itself is the different hats and the different language. So if you have, say, professionals with a medical background and people with lived experience working side by side in the service, as Adrian was just mentioning, to date, many European countries have people with lived experience working in the services, but it's not going very well because they tend to speak different languages and have different concepts about what they see and what they think requires naming and working. So how do you reconcile these two different languages and concepts that are from the sick care model and the healthcare model? How do you combine them in the future mental health services so that they can work together? I think this is a major challenge, but I don't think they should be seen as opposites. Rather, they should be seen in a dialectical fashion as, you can, as opposites that facilitate finding the truth through analyzing these opposites. So it's an invitation to have a more dialectical view of the different perspective that you can have in the mental health services. But I think this is possibly the most important issue facing mental health services today, is to really reconcile the sick care model with the language and the concepts of the healthcare and the model and the language associated with it and the language of personal recovery. And again, I think we can also look at somatic medicine and somatic hospitals, because there these things are also happening, and there these models are also gaining ground. For example, the medical literature is filled with randomized trials talking about mind-body approaches. So this was a paper, I think, from, this is JAMA, so that's a very famous medical journal in the United States, where they showed that mind-body approaches, things like mindfulness, are very successful in managing pain. And so the medical hospitals is doing these things. And in cancer care, there's also a change going on in terms of how people view end-of-life decisions people take regarding the work they have to do. So often there's over-treatment towards the end of life in people with cancer. People are treated literally to death with medical escalation and trying this and trying that, so that people die without even knowing they're dying. So now it's becoming more and more frequent in services that spiritual counselors actually ask people very openly, what do you want to do the last 6 months of your life? Do you want to say goodbye? Do you want to give meaning to your life? Do you want to, have reflections and see if you can reconcile with your faith? Or do you want treatment to continue? And then literally show people what this will entail, what treatment will bring, the side effects and everything. And then, like this trial showed, the majority of individuals will actually choose for just palliative treatment and no more medical escalation. So given the choice, people will opt for the spiritual treatment rather than the medical escalation. So this is important, because how many mental health services are really giving the choice for this kind of spiritual treatment and approach towards mental health challenges? So if somatic medicine can do this, we can do it as well. And of course, there's also very interesting research. I think this was a work from a London group, where they showed, well, actually, where do people stand to gain? So this was from a mental health service, and they tracked outcomes over a year of people with what is called severe mental illness being served by the psychiatric services. And they measured where was change. So there was no change over a year in clinical recovery, meaning symptoms, as measured by rating scales, but there was improvement in aspects of personal recovery. So, meaning, sense of purpose, inviting people to develop agency, think of themselves as being able to lead a meaningful life, those sorts of things. There, it was possible to get change, whereas the clinical recovery was the same. So treatment, perhaps, this stands to gain much more with many people in the services by taking a recovery approach rather than a clinical approach. Okay, so what do we do with the professionals in the new mental health services? What do we do with the psychologist and the psychiatrist and the nurses and the evidence they have in their head and the guidelines they have in their heads and that they try to apply to the phenomenon of mental illness and the symptoms? And I think this is also a very interesting issue when you start to think about real change, because the whole idea of evidence-based practice is a bit in crisis. And that's not me saying that, that's an editorial in the British Medical Journal saying that. And why is that? Well, there's a couple of reasons. The first reason is that if you start to look really critically at what might be the most cost-effective treatment in mental health, then it is surprisingly yesterday nobody guessed it. Surprisingly, it may be what is called placebo. And of course, placebo is a word that means many things. In this context, I mean placebo as a treatment ritual where 2 or more people actually have very meaningful interactions, where you for the first time tell about your doubts and your distress and the solutions you're looking for to another person, which has an enormous effect on people, and then the other one responding in a certain fashion, trying to make a relationship, etc. And placebo, to a degree then, of course, is about the treatment ritual and the relationships. And there's wonderful research, for example, by this man, Ted Kapchuk from Harvard, and he conducts placebo trials. So he tells people actually they're getting a placebo, and then he studies the effect and what are the determinants then of people benefiting from that placebo. And in this research, it was about abdominal pain in the context of irritable bowel syndrome. And he compared doing nothing with fake acupuncture. But the fake acupuncture, the placebo condition, had 2 versions. One was the warm version, where there was a warm fake acupuncturist offering the treatment, so he would try to make a relationship with the person. And the other one was the cold fake acupuncturist, who was sort of doing his job, but that was it, no meaningful interaction. And then, of course, he showed that fake acupuncture was better than doing nothing, but the warm version was even better than the cold version. And the cold version was still better than doing nothing. So this shows you the power of relationships and of a treatment ritual and what that can do to individuals with mental suffering. And relationships, of course, are important. We know that there's a big debate in academic psychology about whether the 400 different psychotherapies that exist, whether people get better through the specific effect of the specific psychotherapy, or whether a lot of the getting better from psychotherapy is really through relationships, therapeutic relationships, things like empathy, authenticity, listening, etc. So this trial was very interesting. It was about psychosis. Many of you will have seen it. It was a huge CBT psychosis trial, and they showed that basically you got better from it if you had a good relationship with your therapist, and it made you worse if you had a poor relationship with your therapist. So this is very interesting because it suggests that then this is mediated by relationships rather than the specific CBT. Also very interesting, medication. So this approach you can do with medications as well, and it's rarely done, but this was a very large trial on antidepressants. And what they did was they tried to find out whether getting better on an antidepressant was because of the specific effect of the antidepressant, or whether it was because of the way the antidepressant was prescribed by the psychiatrist. And as you can see, getting better on an antidepressant had much more to do with how the antidepressant was prescribed than the specific effect of the antidepressant itself. So I think this evidence is not used enough. It's very important evidence, showing that many things are about relationships. Of course, a bit risky, because if this is true, then do you need 8 years to train a professional? I'll come to that in a moment. The other point is, and that's very interesting, and that is that guidelines for mean patients do not seem to work for everybody. And this is a point that Peter Groot from the Maastricht User Research Center is going on and on about, rightly, because thinking that there's a diagnosis that applies to 100 people, and that they're the same because they have the diagnosis, we know is not true. We know the treatment guidelines based on randomized controlled trials are about group signals, group comparison signals that do not apply to many, many individuals. And it's the same with prognostic statements. Prognostic statements are not precise enough, certainly not in mental health. So this whole idea about, you can make a reality by giving people a diagnosis and saying this is a guideline-based treatment, we should do this, is illusionary. And the evidence for that is called the so-called DODO effect. The DODO effect is very interesting. It works in psychology and it works in psychiatry. It means that, for example, in depression, all 400 psychotherapies that you can apply to depression, they all have the same weak therapeutic effect. They don't differ. One is not better than the other. But beneath that apparent small effect of all the different therapies that is the same, beneath that, of course, is the fact that one person will respond to CBT and CBT only, and another person will respond to psychodynamic psychotherapy and psychodynamic therapy only. The problem is we don't know who will respond to what. So when it all boils down to an experiment. Every treatment option is an experiment which you can't control and which you have to find out. So we should be telling people that. It's an experiment with a molecule, it's an experiment with an approach. What would you like? It's the same in medication. We have this, this is the white coat of the psychiatrist. We used to have this antipsychotic that we said is more effective than other antipsychotics. But if you really look critically at the evidence for that, then the evidence for that clozapine is more effective than other antipsychotics, the exception, this will be the exception of the DODO, that all antipsychotics must win because they have equal effects. Unfortunately, the evidence is very, very weak when you really look closely at what it's based upon. So the question is, why do people get better on clozapine? Is that because we believe then that clozapine is more effective and we convey this hope and optimism to patients and then they use that? We don't know. Okay, so with all this background, I think we can propose a few changes to mental health services. Start designing the mental health service of tomorrow. But I think the principles, perhaps, are not so difficult. We know about recovery, we know about relationships and the importance, we know about the importance of social holding, open dialogue, etc. I think the bigger problem is, how do you innovate in an existing environment with existing mental health services, with existing cultural knowledge in the heads of the psychiatrists and the psychologists and the people staffing the services? And everybody wants to innovate, of course, but nobody wants to change. That is the big problem. So real change, I think, is about thinking how is innovation going to be possible? Because all the European countries have mental health services that are systems. So in the Netherlands, we have a mental health services where 90,000 people work. And they have a branch organization, which is called Mental Health in Netherlands, and they protect the rights and the work of these 90,000 people. They're not interested in change. They're there to make sure that people hold on to their jobs, which of course is fine. But we should also look at what the system does. So what we have looked at the literature. For example, in the UK, there have been very interesting randomized controlled trials trying to implement recovery-based concepts and working in mental health services. So joint crisis plans, for example, and personal recovery approaches. And these trials did not work. And that is the interesting thing. They didn't work because the organizational readiness of the services was not compatible with these new concepts. So I think when you talk about change, you really have to look at the aspect, what is about organizational readiness. So what we try to do in the Netherlands is reason around. And we wrote this book. We wrote it with Wilma Boevink. Wilma Boevink is a very well-known person in the Netherlands who sort of introduced the idea of recovery in the Netherlands a long time ago. Philippe de Lespol is a psychologist, colleague of mine, and Michael Milo, he's a public health and mental and e-health specialist. So we said the best way probably to go about is to create small pilots of disruption in a small area, a small scale pilot in a small area. That is the way to go about, not just introduce another system and another blueprint, and then the system becomes a system again, and then there's 90,000 people working in the new system and they don't want to change. So what we said is there's a few principles that we're going to apply, and we're going to try to so 5 or 6 big mental health organizations, we're going to entice them to have a small pilot for change. It's very safe because you can do your old thing and have a new pilot. And the pilot is based on a huge redistribution of resources. A huge redistribution of resources. I'll talk about that in a moment. From the system to the community. It has to be small scale and integrated, meaning working with general practitioners, working with social services, working with social economy. You start with the motivated, because otherwise you don't have organizational readiness. You handpick people, professionals, people with lived experience, relatives, other stakeholders. You offer them a job and you make sure they are the most motivated, because then you can show proof of principle. So you don't start with services who don't want to change, you start with people who really want to change. You don't give them a blueprint, because giving people a blueprint doesn't make them think. They have to be empowered to make their own service. You just give them a few broad principles, and the outcome is not a randomized controlled trial and a health economic assessment of how much money we will save. No, the outcome of this is it possible? It's just a feasibility pilot. So we enticed now 3 or 4 large mental health organizations, insurers, municipalities, to start such a pilot. And it's a huge amount of work, and it's very, very difficult, but it's very exciting as well. And you will say, well, where do you find the money? Because we really make a huge redistribution of resources. And this is the lucky thing. Look at the Netherlands. Did you notice? The Netherlands has more psychiatric beds than any other European country. And why is this? This is because everybody is always saying in the Netherlands, we need more beds. And why is that? Because there's no social holding. ACT teams or FACT teams have an area of 50,000 population, that's 8 FTE. What can they do in an area of 50,000? They don't have the resources to have a meaningful impact. So people, there's no social holding, so people relapse, and then people say, oh, we need to go to hospital. So this has been a sort of revolving door issue, very strange. But we see these beds as a huge resource. What we want to do is these beds are now going to be closed, of course, because authorities see, well, we've got too many beds relative to other European countries, we need that money. So we're going to make sure that money remains in the mental health system, but we're going to redistribute it to the pilots in the community and create social holding there. So what is this community then we want to create? Well, it is, we say mental health services are not mental health services, they are basically a healing community in a small area of 10,000 to 20,000. That is the new mental health services, staffed by people with lived experience, relatives, professionals, and in an area of 10 to 20,000 there will be, we calculate about 300. So they know each other. So how do we do that? Well, we go to the mental health services, we say we're going to dismantle you, this is the mental health services, and then we're going to create neighborhood communities. Well, we're not telling them this. We just ask them to create one. You know, one small neighborhood community. And it's not really neighborhood. It's not the geographical definition of a neighborhood. We don't tell people it has to be in your neighborhood, because some people find that very stifling. They don't want to be in their neighborhood community. They want to go further along. So it's just a metaphor for a community of about 300 FTE mixed with different hats working together in an area of 10,000, 20,000 people integrated with 10 GP practices. So we started now 3 or 4. We're busy doing that. So that's the idea. And this is the most challenging bit. We ask people, the motivated people working there, to reinvent themselves in such a way that what they have in their heads in terms of language and concepts is used in such a way that they see themselves as from the same planet and see themselves as being able to partake in all the different roles that are there. So in the old system, you know, the one making the diagnosis is the professional. But of course, it depends what you think a diagnosis is. If you want to see where a person is in the recovery process, you can also call that diagnosis. That is typically something that a person with lived experience can do much better. So we ask people to have Socratic dialogues or other ways of interacting with each other, really in such a way that they come up with solutions of talking the same language of, or at least understanding and being versatile in all the language and the different roles. And this is very interesting. We have a conference in October in the Netherlands, the sort of multi-experience conference where we want to sort of find out if this is going to be possible. So what are these people going to do? The 300 FTE, we calculated we have the resources for 300 FTE in an area of 20,000. It's not, you know, we don't need more resources. We've got plenty of resources already, but they're all tied up in hospital beds and bureaucracy. So we're going to redistribute that. So the basic model, of course, is that the community is about providing social holding and is about activating connections and offering local respite, working very much upon the principles of open dialogue and about relationships. So that is the basic principle. It's not a blueprint. We ask people to consider this as a principle. And another very important principle is integration with social services and to make sure that there is a user-driven social economy, including education, of course, that is taking place in the community or that the community has impact on. And this is a very exciting, probably even perhaps the most important part, because in countries like Belgium, you have a social currency. You have a system of social currency in a different currency than the euro, a system of checks, where you can pay people for helping each other. And these systems are very interesting, and they're also approved by the fiscal authorities. So you can use these to create a social economy, and some cities are experimenting with these, for people who have really still a large distance to the workforce. And you need a social economy, otherwise what you get is that people receive treatment and treatment and treatment, but they don't need treatment, they need a life, and you get that through a social economy. So this is also a very important aspect of the new mental health service. And then, do you want psychologists and psychiatrists? Well, we think yes. We think, and this was a debate yesterday, people said, well, psychologists, okay, psychiatrists, I don't know, maybe. So I think the point is somebody who's just done psychology or has just done psychiatry maybe is not of much use. But I think it is useful if the psychiatrist really specializes in psychopharmacology, knows his stuff about the brain, knows about impact of molecules, and really helps people make a choice if they want to and find the molecule that they want or not want, or want to stop or taper off or whatever, then it is useful to have a psychiatrist and who also knows something about somatic health, particularly in mental health services and liaising with the GPs. So, you can discuss, you can debate the salary, of course, and then, what if he's a psychopharmacologist, what is going to be the salary of psychiatrist? Does he need to have, you need to pay him as much as he gets now? These are all very interesting discussions. So, these people can work out as well. And of course, there will be changes in that area as well. But I think psychopharmacology and being able to experiment with molecules, if you want to, should be done by people who really know what they're about. Somebody yesterday was saying, well, okay, but psychiatrists these days don't know anything about the brain anymore. They don't know about psychopharmacology. They should really retrain themselves. Well, perhaps that's true. But I think it is important. And of course, psychologists, well, you can say that, psychologists really, you need specific psychotherapies, and you need psychodynamic, and you need dialectical behavioral, and you can also say, well, a psychologist, same as with psychiatrists, somebody who has really experience with psychotherapy, and has seen many, many individuals for psychotherapy, of course, has valuable experience to bring to the surface, just as a psychiatrist has valuable experience to bring if he's been prescribing lithium, for example, to many, many people and really knows what it can and can't do. So I think there is room for professionals in the mental health service. Maybe this sounds a bit strange coming from a psychiatrist, but I'm not convinced that, like some people are saying, well, you don't need psychiatrists anymore and psychologists. You know, it's all about relationships. Maybe, but I'm not so sure. I think there's also a degree of professional expertise that you can use in the service. So, but the important thing is the treatment that these people can offer should not be about, here's your diagnosis, and this is what the guidelines tell us we are going to do now. It should be about really, really trying to follow this incredibly complicated, non-linear process of recovery and really trying to be keen on when do I have something to offer that can help people with the person, that can help the person with what is happening in his or her life now. For example, if there's relationship problems, perhaps then psychotherapy can be helpful. Or if a person has a particularly severe spell of depression, perhaps then psychopharmacology can be of use. So not guideline-based, but context-based, phasic over the course of the nonlinear process of recovery. That would be a different setting. So this is what I had to offer. I have yet no data, to show you about the impact of the pilots. All I can tell you is that it is a process. Maybe it's a process of recovery of mental health services, if you like. It is just trying to entice the services to really engage in something disruptive, a pilot, and see if it works, and using the motivated people who really want change, working side by side with people with lived experience, finding a common language, and then the outcome is feasibility. And we hope in a couple of years that more people will start piloting, and that the piloting itself will become a movement that will actually help facilitate change. So with that, I come to the end of my lecture. Thank you very much.